too. And I think that we have to realize that if you get on the front end of disease, it costs a lot less than trying to treat the back end. And yet we've never, in many places, we've never prioritized that. And so I think that as we think about what it means to provide care in a community and to get into the community level, to really understand what it means to prevent disease early on, you'll see a huge amount of cost savings. But that is different for different communities. It's different depending on who's engaging in those conversations. But what it fundamentally comes down to is leadership. Leaders have to decide that they, if you have power in this world, you have to decide that you're going to wield it for good and think about what that means to actually translate that into those that don't. Because ultimately, there are choices we could be making that are different. We're not making them right now. And so, to me, it starts there. I would argue everybody in this room has the power, is a leader fundamentally, in the fact that you're sitting here part of these conversations. So I think it's incumbent on us. I think it's incumbent on those that have the ability to implement change, to dedicate time, resources, and effort to solve these. But it goes back to the ultimate point. The cost of not doing that is really too great. Just accept and wake up to that.
Thank you. I would just add one point, that I would say that the cost of treating the back end is far more expensive than addressing the front end. And that's the common way we're doing the back end.
Okay, we have a question, gentleman in the second row.
Austin Demby with Health Resources and Services Administration. This is more around the issue of interprofessional training. I think we all understand and see the value of it. It's really a team-based effort in implementing programs. But I did hear somebody mention the tribal issues around it. I think some of these professional institutions feel very, very strongly about their constituents and their compensation differences between nurses and doctors and other healthcare workers. And when you put them in the same space to work as a team, there is a natural tension that one has to overcome. Clearly, there are opportunities for addressing this at the pre-service level. There are opportunities for addressing this even more, maybe a little bit more upstream in the in-service environment. What has been your experience, and how do you address those tribal issues to actually get into professional work at its best in the field?
If I can answer. I just want to add one point, that there's a huge gender component, especially around nursing, which is something that we see consistently across the world with few exceptions. So I think nursing is a profession that's another thing that we need to do, is kind of elevate it and the need and the importance of it. And that's what really we've been trying to do with pediatric cardiac nursing, but I see it across the board that it's a big, big problem. There are countries today in Eastern Europe that are not educating, that are educating probably about half of the need of their nursing workforce, because the profession is not considered prestigious in the country. To answer your question, my experience has been that, and I'm going to say this, but the two communist countries we work in, there's actually not big pay differential between doctors and nurses. And they have plenty of both in Vietnam and in China. And there's a lot smaller power differential that I have seen compared to, for example, India, Brazil. Though I don't know why and what's the history behind that, but it is that really brings a lot of issues when their starting point is even much lower for a lot of the non-MD professionals. And you try to address that with, again, leadership and with example from leadership of, again, respect for the profession and respect for the work that they do. A lot also comes with education. So more education and training brings actually better satisfaction with your work. And in the work that we in the past did with nursing retention in South Africa, we found that pay actually was not the most important thing to them. For them, the most important thing was they were not leaving when they were feeling respected and when they were feeling heard and when they had opportunities for professional development. So education is key to sustaining actually workforce. health workforce.
Thank you. We have a question from the web, and the question is, what strategies might we adopt into the practice of our faculty of teachers? How would you approach that if you were working with faculty and developing that concept further? Our web people are thinking hard.
Just repeat the question so that we are clear.
What strategies would you recommend that could be adopted to embed social accountability into the value system of faculty, of all faculty?
Yeah. I would say the first thing is to develop a dedicated program in the orientation. Maybe we should say reorientation, depends on where you are, of all faculty to work in the new ways. And in that reorientation, the message of social accountability needs to be brought to the forefront. So at least they know the purpose of their institutions is not about their jobs, but it is about stopping that normal death, which really they should reject. That is step number one. Then the next one is to go to their employers, because they are also behaving the way they do, because society sees them in the way in which makes them behave the way they do. So we need to engage with governments also to get that social accountability interaction and message recognized by the ministers of education, of health, of finance. And once that equilibrium is achieved, that all of us are working to stop normal death. I mean, with it, death being normal, and that's the reason we exist, then we will start to see some behavior change.
Okay, thank you. I'll ask all of you to please give a warm applause to our panel of one for their we're going to now have panel number two, which is delivering outcomes, and that panel will focus really on the policy part of what we're doing. And there were lots of comments around social determinants of health. And if we look at the SDGs, each of them really cover everything we need to do in terms of accountability. I'm just going to remind you that on the back table, there are copies of the political declaration that was discussed yesterday on universal health coverage. And when we think about that, we really need to think about systems thinking. So a lot of the comments here, we're just talking about different things that are amiss in different places. So we need to call on all sectors beyond just the health and education sector. So the industries, private sector, communities, et cetera. I was at a talk last night on antimicrobial resistance, and the Minister of Health from Colombia, Juan Uribe, talked about treating AMR and the very challenging situations they've had, but talked about that while Colombia is a middle-income country, they have excellent care, and they can treat AMR in their cities as well as we can in the best of institutions in New York. And but that when you go into the rural areas, the more distant areas, that quality varies because of capacity, money. So one of the sectors we call upon, obviously, is government, and we've had the constant want to make sure that all governments really invest in the education and training, that spend the amount of money they can appropriate on health. And without that money and those resources from both public and private sector, we have many more complicating challenges. So with framing that, may I introduce our wonderful second panel who are going to discuss many of the policy solutions. So our moderator is Catherine Ellington. Catherine is a community health advocate, and she works with the technical work group and WHO on equity, and will moderate the panel. Joining her is Björg Pálsdóttir. Björg is our co-founder of THEnet and leads a thematic work group with the WHO on data and evidence hub. Björg has a early career experience with the Peace Corps. And next is Dr. Geneviève Moineau, who is the president and CEO of the Association of Faculties of Medicine of Canada, which is the association that joins all, it's our educational and practice association, and has done a lot of work in social accountability in practice across schools of medicine. She has developed agreements and done a lot of work with WAMC and works as a pediatrician, and also has served as the Associate Dean of Undergraduate Medical Education. Next, we have Kerry Saldaña, and Kerry is with the Office of Health Systems with USAID and Bureau of Global Health. Kerry has over 20 years of experience in various areas of public health. She was Deputy Director of the Infectious Disease Office. She has found including responding to the earthquake in Haiti, and more recently USAID's response to Zika. And she also started her career in the Peace Corps. And then finally, our esteemed Dr. Jim Campbell. Jim is the Director of WHO's Office on Health Workforce. He has been one of the lead movers in the global strategy on HRH Workforce 2030, and has really been a champion to try to bring the many, many years of work, and that will hopefully continue to flourish as it has, to make changes in health workforce. So with that.
Good morning. Can you hear me? Good morning. Better? Great. So I'm Catherine Ellington, and we're going to get right to it. I guess as I'm reflecting on panel 1, and we're now moving to panel 2, one of the things that struck me about the stories that I was hearing is a clinical term that comes to mind from Dr. Franz Fanon, who talked a lot about what cognitive dissonance is. And so what we find is that individuals, families, communities, the conversations that we have beyond this room, I often say the conversations we have around the sofa or at the breakfast table are as important as the conversations that we have in our institutions and beyond, because in health, there is an enormous, it strikes me that there's an enormous amount of scientific advancement that's not translated in communities, that remains sort of a sticking point, which makes us all educators in one way or another, individually and collectively. So I just wanted to add that reflection that somehow a 19th century concept of cognitive dissonance is still rampant throughout our health systems, and that trainees and those who train, those who develop professionally have to revisit. Sometimes you have to revisit terms. You have to revisit, you know, that's what CME is for. That's what the trajectory of training should do, is help you to revisit and to advance skill set, both hard skills and what we know as soft skills. So I'm going to get right to it. The first question is for Jim, and the question is around how development partners and networks in the room and beyond support the country level implementation that WHO and others have called for. How do we get to it?
Indeed. So good morning, colleagues. Great to see some familiar friends and faces in the room. Great to see representation from the professional associations, and I'm not sure what the audience is on the webcast, but good that we're putting out there. Just a quick thought, just before answering that specific question, just picking up on some of the discussion in the first panel. I was at an event yesterday evening with the UN Special Envoy on Education, the former Prime Minister of the United Kingdom, Gordon Brown. and they launched a report transforming the education workforce, how to have learning teams. So when we start thinking about the Sustainable Development Goals and the intersectoral knowledge and the opportunity, we talk about what action we need to do. One of the things clearly is to make sure that we're actually watching the evidence from other sectors, first and foremost, and start to join the dots on some of this. As we're doing that learning, the competency conversation that was going forward, I'd just like to thank the over 200 people that are involved, experts from around the world, that have been working with WHO to do a global competency framework for universal health coverage. And that final document will be available online for peer review consultation this next month in October. And I would encourage and invite all those here today and other networks to look at that and review, because all the competencies we're talking about, patient-centeredness, engaging with the community, empathy, putting people first, interprofessional education and practice, are all covered in there. And it really builds on the whole issue of social accountability. As you think, it's almost 25 years now since we've had a definition of social accountability. And yet we saw, even in the high-level political declaration on UHC yesterday, social accountability got changed to social responsibility, because a lot of people, sort of thought, oh, socially accountable, maybe we need to change that, because the politicians are not necessarily familiar with what we're talking about, the diplomats. So we've still got, even after 25 years, we've got an awful lot of work to do. And specifically then, Catherine, to your question, you started with development partners, and it's wonderful to see Kelly and USAID here, and also Tom from HRSA. It's not just development partners. This is a domestic challenge in high-income OECD countries, as it is in the low and middle-income countries, and we heard from Professor Omaswa and the work of AFREhealth. It's not a development issue. It's a health, education and employment issue that all countries are facing challenge with. And so how do we get whole of government responses to some of these challenges? We have member states around the world endorse the global strategy, and it's there on human resources for health, the whole process of socially accountable education, transformative education in all countries. They've endorsed the primary healthcare declaration in Astana, which again puts a people-centered integrated health service first, with an education system, including the faculty, including the students, the graduates, linked to employment in primary healthcare, and to trying to strengthen the distribution and the competency of the workforce. It's there in the member states' agreement around national health workforce accounts to actually measure and report progress to the World Health Assembly every single year. What actions are you taking on a social accountability education framework? And member states, that's one of the indicators that they have to come back and report on. So we'll start to have an accountability on social accountability after 25 years of a definition. Why? It's going to prompt a discussion, hopefully. I was speaking to Charlie from HRSA this morning, and the US are in the process now of reporting to the World Health Assembly on their health workforce for this year's National Health Workforce and engaging with many other stakeholders. And that's just a policy dialogue that may say, what are we doing? How are we doing? Or what are we going for? But some clear actions that I think we can look at for all partners. It is very much an opportunity to say, okay, what data have we got? First of all, what's happening? What's going on? And to try and inform the government's data systems, not the project data systems. So we've got to build capacity and put data into the public domain for any of us to engage into the research, the accountability discussions around what's actually happening. From that data, let's enter into dialogue. So really start to say what's happening and what's your role as ministries, government officials, implementing agencies, health professional associations. What's your role around that dialogue process to say, are we anywhere near matching the population needs in terms of our service model and the distribution of our workforce with the skills and competencies to be effective in an interprofessional, multidisciplinary primary healthcare team. You know? And if not, then what action, what decision are we going to take, and what change are we going to make? So there's just some thoughts and suggestions, but it really is not exclusive to low-income countries. This challenge is going to be faced everywhere in the world. WHO is based in Switzerland, and trying to distribute the workforce in Switzerland, which is not a huge country, population, is a major, major challenge, and they are spending considerable amounts of money. So it's for everybody to be involved with.
That's a good move to talk about the money. I think no one was clearer yesterday than Jeffrey Sachs when he spoke about it is about the money, that there is an enormous income inequality, that there are a few people, and he began to name names about the wealth that needs to be sort of shared. And I probably would add institutions, philanthropic institutions, people who family wealth. This is an incredible time in globalization where money has been forthcoming, but values and the reshaping of what we believe to be the priority is before us. So I guess with that, Björg, I would turn to you to ask, what is the current evidence on the return on investment, social accountability strategies around the world?
Sure. I think reflecting on when we started out more than 10 years ago, first when we started talking to people about evaluating the impact, people said, you can't do that with education. You know, that what was being counted was number of graduates, and then very often, maybe through some cases, there were alumni association where they were tracking where they were going, but they weren't really looking at impact or what is the effect of, is a curriculum actually designed to meet needs? And as a non-health professional, that was kind of shocking to me, that wasn't really what was driving education. And I think what you were talking about in the beginning, this cognitive dissonance of we have been working in silos, and we've been also reluctant to measure what's hard to measure. And I think one of the things that has been a great learning experience from my perspective, and I think the word social accountability often gets in the way because people see either they get stuck on the word social or they get stuck on the word accountability. But ultimately, what it is about is design, education, and training, lifelong learning to meet needs and actually work with other stakeholders to define the needs. So it's really not, you know, some brilliant new concept, but it's something that, you know, it's about shifting the way we measure success, I think. So what we've been doing is we started obviously with the lowest hanging fruit, looking at graduate tracking. So when we talk about social accountability strategies, what our network of schools that have sort of a mandate of social accountability focusing on all start with the needs in mind when they design their curricula. Mm-hmm. They recruit for retention. So they are specifically trying to address needs in underserved communities. So in some cases, those strategies focus on if it's about rural or indigenous health, they tend to recruit from those communities. Other of those schools actually try to design criteria that measure this kind of empathy and other psychosocial factors that I think might be more likely to work in underserved settings. Mm-hmm. It's also, another principle is training where you're expected to work. If you're training, even if you bring rural folks and you train them in the city and that they work in a tertiary care hospital, they are most likely to stay in those cities. So there are some other strategies, including, and that was mentioned before, is the curricula actually focus on much broader than just the separating this basic and clinical science. You engage with not only theoretical discussion, but you have service learning, so students spend time in communities, not as tourists, but actually living in those communities. So there's strategies that are implemented in different ways, but what we saw is that we found schools working in very different systems, high and low income countries, but sharing the need, and they ended up with very similar strategies. So what we initially started at looking at was tracking the graduates. And from comparing the graduates from our schools, which are located on all continents, they have a much higher percentage of people actually, remaining or going to work in underserved communities. So I'm thinking of the Philippines. We did an impact study in the Philippines. We have 2 schools there. We were able to do a comparative study. And what was fascinating to see was that the graduates that were trained in these socially accountable schools, I hate to say socially accountable in the sense that striving towards, it's a means to an end, that what they were doing is they were much more likely to be, they were actually, I think 95% of them were working in the Philippines 10 years down the line, sure, versus 29% of those who were trained in the sort of conventional model. We had, I think it was 49, I have the figures here, because 49% that let me see, 49% of graduates low-income communities versus 11% of those from the conventional program. So we see there is impact. And so you could look at it at systems level, you could look at it also at the level of competencies. So we recently did a study in terms of comparing, talking to clinical supervisors after graduation, and they had the graduates coming from these socially accountable schools had better leadership skills, better communication skill. They were more collaborative, more focused on teamwork. So they're real things you can look at, and I think that is that was one element. Another thing which we've been doing with our schools, but we also were excited to work with Touch Foundation, has this program in Tanzania where they did a training programs which moved the clinical training of, I think, doctors and nurses into smaller hospitals from the tertiary care hospitals. And the return on investment in terms of quality of the education, quality of the service delivery, because they would then bring the clinical trainers from the larger cities that would do the training, train local staff that were there, in terms of cost saving for patients and the hospital that didn't have to transport patients for complex deliveries, or lives that weren't lost, babies that survived because they could receive the care there. So there are ways of measuring, and I think it's not going to be linear evidence, and we need to do more, but we need to build on that learning from, like you were saying, Jim, other sectors, sure, education, etc. So
great. So I'm going to switch things around a little bit. Geneviève, how can accreditation systems be a catalyst for change? I think that's a continuation conversation.
Thank you. So again, thank you for having me, and it's a pleasure to be here and having the opportunity to make new friends. So in Canada, as you know, just to give you the context, we are very fortunate to have a system where we have universal health coverage. Our health system is supported by our government at a provincial level, and our medical education system is supported and subsidized by our provincial governments as well. So this actually is a combination that has allowed us in Canada to actually bring into our accreditation system for our medical schools a set of standards that are actually focused on social accountability. In Canada, we have 17 faculties of medicine. So as the president and CEO of the Association of Faculties, all 17 of those deans are actually on my board. We also have 4 public members. But what's extraordinary is, as one of the sponsors for the accreditation system, we actually agreed to bring into our accreditation standards a standard that speaks specifically to the social accountability of our faculties of medicine. And it's our standard 1.1.1. So we know when something's number one for a reason. And it actually specifically states that a medical school must actually be set up to meet the needs of the population that is meant to serve. And it actually has the word social accountability in the standard. Mm-hmm. And it says that the medical school must demonstrate its social accountability in the fact that it has a clear description of its social accountability mandate in its mission statement, that there's a clear construct around the admissions process and the curriculum, as well as the way that the learning experiences are set up, as well as the assessment. And it must also demonstrate that, in fact, its outcomes bring us back to success around its social accountability mandate. So imagine being a dean of a medical school and having to do that. So I'm actually very, very proud that our deans actually agreed to do this, understood that it was their responsibility to do so. We have other standards in our standard set that actually speak to many of the other areas that you mentioned today. We have to be teaching our students about social determinants of health. Mm-hmm. We have to be teaching our students around the most important health issues for the populations. We also have a standard specifically around cultural competency, and we have actually added specific words around the competency for our Indigenous people in Canada. We also have standards around service learning, standards on leadership. We have to have leadership curriculum for our students. So really it's a whole cadre of standards that really bring us back to our understanding that we are there to create the healthcare professionals that will serve the Canadian population. So again, I think this is one part of a complex set of needs to address overall social accountability.
Thank you. Can I just add to that, just on we're actually in the global strategy on human resource, the milestones for 2020 actually ask member states to report back on, what steps they're taking. So that's next year. So we will be convening with partners ECFMG, the Ministry of Health in Turkey, an international symposium in December on accreditation and regulation to actually start to track some of the progress around the world, looking at Canada's model and many others around that. So bringing in the evidence of what is working where, again, on some of these regulatory mechanisms and accreditation standards. So I'll look forward to sharing that, the results of the symposium and the new knowledge that we will generate from it.
Great. So Kelly, as we move along policy conversations, the data becomes really important, what we're measuring, what we're seeing. And so one of USAID's health system strengthening goals is to increase the availability and the use of human resources data. Why do you see data collection as essential to maximize the impact of the health workforce on quality of care and for universal health care? And if I could add, what data related to education should be collected? But you just dive in. Go ahead.
Sure. I'm actually going to change your question a little bit just because we're trying very hard not to focus on the data collection and focus much more on the data use. And I think a lot of times it's always data availability and use, or data collection and use, and it's always and use. And we feel very strongly that use never comes. It's always implemented in this very linear fashion. First we get the indicators right, then we figure out the collection, and then we're going to do the collection, and something happened along the way and we have to go back and start over. And so we really want to flip that and say, what do we need to use data to make it used in the system? And I think one of the earlier panel talked about really focusing on the outcome, that, you know, and making sure that it is not acceptable that children are dying or that women are dying in childbirth. And so what we're trying to do within our health systems work is the same thing, is not focus on sort of the output or the outcome, but really what are we trying to change in the system? And we think that we're trying to build systems that are equitable, provide quality care, and then optimize resources. And so the biggest resource in the system is the people. And we need to make sure that those people are used in the best way possible, and that then they use information in the best way possible. And so really sort of thinking about how we align the workforce that we have to the disease burden that we have, how we can be responsive to communities and what they need, how we understand what sort of competencies the workforce we have has, where they're deployed, and all of this. All of this requires data, but really, and so obviously data collection is very important to that, but really trying to do it from a perspective of use and identifying ways where we can use that and make decisions based on the data that we have while we make that data better at the same time, and while we're responsive to feedback from communities and patients, and so that we're both building the data and the collection, but we're really starting with the use piece. And so I think the National Health Workforce Accounts that Jim has been working on are really a useful construct in that, because they take a very sort of systems thinking view to everything that goes into optimizing these human resources. So it's not just what competencies do they have and where they're distributed, but it's sort of thinking through the planning and well, where do we want to go, and what does the workforce look like, and how then do our production of health workers line up with that, and where do things need to change there, and really being able to sort of capture all of that and have that information to be able to then make decisions, and to start with hopefully making the right decisions and then improving upon them based on feedback.
Thank you. Anyone else want to add?
Can I just say that the national, to Kelly and the USAID team who've been supporting WHO on this, and the US government in the resolution in particular was very supportive of this data use concept, and therefore strengthening the engagement in national health workforce accounts. What's the impact on this? So this year we're collecting the baseline for the SDG 3C reporting.
Sure.
We have 134 member states to date, counting. I got the information before I traveled to New York, who have reported on national health workforce accounts. That is unheard of. Anybody involved in the health workforce space for the last 20, 30 years will know that it's almost impossible to actually think. And the impact of this is that we have a global public good. So if you go to any country now, you don't need to go and spend more money to go and collect data because the government is reporting it and it's available for everybody. And the whole systems approach, what they're also recognizing is even when they don't have the indicator, they're taking action to actually say, how do we get that so that we can have it in our policy discussions?
Sure.
So, and this is in 2.5, 3 years of the decision to creating this baseline. 0 to 134 is a phenomenal success, and so thanks to Kelly and her team and many other member states for their engagement.
So we're coming down to the last questions, and you all can begin to prepare for Q&A. But this last question is really open for everyone, and it's about social accountability calls for educational institutions to assess their graduate outcomes and impact on the health system and the communities that they serve. What are the outcomes and impact we want to see from our strategies? What are we really what's new, what's old, what are we trying to see in terms of impact that comes out of strategies?
Well, I think, tying back to what Kelly's saying, is that education institutions need to be thinking downstream. They need to say, are we contributing? Are we strengthening the system? What's our role? And ultimately, for me, social accountability, if you're not measuring your impact, how can you know whether you're socially accountable? It's really about, and then, aligning. Actually, the second part is the most important, is acting on it. Fine, you do your assessment. So I think what we want to see is we want education institutions to work very closely and integrate with health service delivery sector. We have these fragmented conversations, and there's a lot of waste of resources. So we want graduates to come out, and we want them to be lifelong learners. We want them to be folks that are constantly looking for knowledge. They are engaging with other stakeholders. They understand health from a broader perspective. They work as team workers, and they have leadership skills that help them become problem solvers.
Sure.
And institutions need to also, it's not just about the graduates, it's about, well, how are they meaningful in the communities where they're based and where they're learning? Are they contributing to the neighborhoods that they're working in? Are there the communities that they're serving partners, active partners in the planning and education and delivery? And also you need, I think education institutions need to work across sectors, and this is, again, it happens at micro levels and macro levels.
Right.
We really need to have folks that are constantly out there, ready to make change, open to focus on quality, so they become, so it was just at a recent conference hearing about medical students actually, when they were working in the hospital, providing feedback to the hospital administration, talking about gaps that they saw. That's the kind of graduates we want.
What I'd like to add to that is that the other very important piece is, in fact, who we bring in as our health workforce. And certainly in Canada, we're having a very serious conversation about improving the diversity of our health workforce. In medicine, we have made some progress, but we need to continue to be able to create appropriate pipelines or other ways to bring in more Indigenous healthcare workers. For us also, there's a language question. We need to make sure we are training individuals who can care for patients in both of our official languages, et cetera, and that have an understanding that they are there to serve. I think that that hasn't always been the case, certainly in the environments that I'm most familiar with. We don't actually need the best and the brightest. We have stopped talking about that. It's not about that. It's actually about bringing in individuals who understand that their whole life's work is going to be about serving their patients, the populations, serving the system. And that's a very different mindset than where we were. And I think that that's probably the most important change that we can make. If you bring in the right people, they will have all these other attributes that we're looking for, and they will go in those communities that need them most. And that is not always easy. So if you have an easy solution to that, please let me know.
Well, I was just going to build on that. When you first asked the question, my first instinct was, what are the outcomes we're looking for? We're looking for health. But it's even broader than that, because I think, as was alluded to earlier, we're looking for overall development. I mean, the health sector is a labor-intensive sector. Even with the advent of technology, it's still going to be a labor-intensive sector. It's got opportunities to bring girls and women into the workforce. It's got opportunities to bring youth into the workforce that are often left behind in some of these countries. And so it is really thinking sort of not only multi-sectorally, but sort of as broadly as possible about where are we getting these workers from? How are we training them? And then I think, to the earlier point, it's sort of checking back on each of those different perspectives. So what do the educational institutions think the workforce of the future is? And does that align with what the Ministry of Health thinks the workforce of the future is? And does that align with what the private sector thinks the workforce of the future is? And is any of that meeting the community's needs, and sort of being able to have those conversations and bring people together and to collectively chart a path forward? But I think there's lots of opportunities. So ultimately, I think we should be measuring on our health workers producing better health of populations and countries, but also are we producing better economic returns and development in the population?
Thank you.
So building on what the colleagues have said, let's be clear, one thing we don't want is to be measuring something like the MBA ranking.
Right. For the USC.
Which is trying to understand, you know, where are our graduates and how much money do they earn? Because the commercialization of medical education, of clinical education, is a real concern around the world. The fastest growing part of our health professional education sector is profiteering from this. Sure. So trying to say, we will guarantee you a career in XYZ if you pay our premium price for education. So I think that's what we don't want. What we do want is equity, the whole issue of health for all. We're trying to have an impact on population health outcomes and the distribution of a workforce. And we need to be connecting the dots much, much better. We need to be commissioning service. We need to be commissioning employment from our education institutions. We want them to partner for the public, which is healthcare for all. So we want them to be actively engaged in saying, yeah, 10 years, like the Philippines example, 10 years after graduation, we have X percentage of our workforce still principal health equity, rural care, rural health, urban, whatever else. So we're actually starting to measure that survival, that retention in the public purpose of healthcare. And then we have to recognize that beyond that, career decisions, lifestyles, individual choices will change, as many people in the room here, as you get more experience and more knowledge, families around you. So we have to recognize that will happen. But if we can instill that belief, that ethic, that practice into the institutions and the faculty and the students, health for all will be the dividend that we get.
Thank you. So I think those were the remarks. We need to now open up the Q&A session. And so, okay.
Hi there, I'm Barbara Maxwell. I'm from interprofessional.global. So of course my question starts with something about interprofessional. So we're currently looking at that 10 years from the WHO framework for interprofessional education and collaboration was published, and trying to do a 10-year global update for where are we now. And what we're finding is we have lots of movement in the education sector of preparing healthcare providers to begin their professional lives. But there is a huge hole in the workforce development side of things, of preparing people who are actually our workers. And if we're reliant on those students, that trickle-down effect of these students coming in who have no power and authority to change the system, we're never going to get there. So my question is, how do we initiate policy change that will allow us to impact the actual workforce rather than the future health workforce?
Fascinating to learn. We look forward to the evidence on the 10-year review, and that's the whole thing, the education and the practice. And I fully agree. The global strategy, the first strategic objective is to work with the team that you have today. That's where we can have greatest impact on the service models, the configuration, because producing the future workforce is going to take time. The evidence that we've seen around this is that inevitably this is a leadership issue, where we see leadership in a health facility, leadership in a health jurisdiction for interprofessional practice. It starts to come through, but it does tend to be linked to single leaders rather than an institutional response. And so how do we change behavior and practice for people in their standard businesses is part of that challenge. And the role of all the professional associations here has to come to play. And we're looking forward to that. On several of the professional associations are here. How can they work with their members, their clinicians, their support staff to try and drive it through, enable the leadership? But it is, I agree, it is a major challenge.
So USAID's done a lot of work on quality improvement at the facility level, and I do think that some of those methodologies do bring together different health professions, because there's a whole approach where you're identifying a problem that wants to be worked on. Say it's, you know, children are dying in childbirth, but then getting all of the health workers in the facility together to brainstorm sort of what they think might be something that they could work on to solve that problem, then implementing solutions and tracking their progress and doing that in a sort of iterative fashion as things improve. And so it takes much more of a team-based approach to problem solving and improving overall quality at the facility level, which really does bring together different cadres of workers collaboratively to solve a problem.
There's a spot in between. So there's marvelous work happening in practice. There's marvelous work now happening in the educational world. But when we know there's strong evidence for things that we should do that creates things like psychological safety in the workplace, and we're not training on any of those, that's where the hole sits. Beautiful work, but without the support of training, but we're trickling into the healthcare workforce. A hole in the middle where the rubber hits the road, I guess.
And all you need to fix that is to be working, again, you know, in an intersectoral manner with lots of leadership, and it probably requires a bit of a culture shift. That's all.
Well, and adding to that, well, I think, you know, it's so much about culture as well. You know, we've all worked at you know, you could look at the education sector and then, you know, service delivery. And then we've got social systems, gender issues. We've got, you know, the whole issues of, you know, race. You know, there's so many issues that influence that, your role, because the issue is very often power. So we need to change our reward system. We need to change. I mean, and it's going to be a cultural change. So it will require both, I think, legal framework and valuing maybe some ways of accreditation, you know, for faculty as well. But I think also an accreditation of clinical training sites, you know. So I think it will definitely be a multiple stakeholder and, you know, effort to change that.
We have a couple more questions. We have one. I think the gentleman. I can't. Right, the gentleman with the dark glasses had his hand up early.
It works right now. Thank you very much. My name is Marian. I'm coming from Slovakia, and I'm the Vice President of the International Federation of Medical Students Associations. But right now, also a fresh doctor, a graduate, so I came from this pre-grad environment into practice right now, so I can relate to all the problems we are discussing right now. My question will go a bit into a leadership question. And as we know, there are huge disparities between countries when it comes to understanding, implementing, and working with social accountability and health workforce issues. And sometimes I feel that it's a bit like with climate change. If you believe in climate change, your foreign and domestic policy will look like you're battling climate change. If you don't believe climate change, you know how things look like. So my question would be, and if I can use the parallel from the previous panel when it was said that people are dying and it feels normal or it's perceived normal. For example, in my country, when you are going out of med school or health school and you do not know things, you are not trained, it's normal because the practice will teach you a lesson. And this is the way how we are doing things in our country. So my question is there any way how can policy impact the attitude of current healthcare professionals or deans or those leaders of medical education, or do we just need to wait for a fortune that our leader or Minister of Healthcare or a dean will come to the position and they will have this understanding of the importance of social accountability?
So I understand your question in short to be, where are the disruptors? Where are those who will be catalysts, right?
Fabulous question. Always the best questions come from the student. Well, an alum student and now a new graduate, but always from the younger than me. So two things have to happen. Number one is that you actually have to bring into leadership positions or positions of power and influence the right people. So, right, in many countries, that means you have to be voted in. And so, again, that's not necessarily directly within our realm of influence, but we can certainly, again, through the work that all of the partners do here, by providing data and information and feeding that to the right places, we can help a little bit. But we all know some of us are in countries where we wish we had slightly different leadership than we do. From the perspective of the institutions, you mentioned the deans, et cetera. That again, requires the wish and will of the universities. And unfortunately, in many countries around the world, universities are more concerned about, in fact, their rankings, their international rankings, which are based on research publications, et cetera, more than whether faculties of health sciences and other areas are focused on social accountability. So it is a big problem. You put your finger right on it.
Two of the questions, the gentleman here. And go ahead.
Just a few things that to comment on and a question as well. My name is Mary Shostark. I'm a physician assistant and I work for the Yale School of Medicine physician assistant online program. So that was one of the big disruptors in the community, is having an online physician assistant program. But one of the things that it has given us access to is being able to provide people an education in rural parts of the United States. So it's really amazing that we have these students in all different locations. But one of the challenges that it presented me with was, how do we create an interprofessional environment when our students are siloed on little internet bubbles, right? So I created a virtual interprofessional education seminar in which I called all the different schools working with NYU, School of Speech and Language Pathology, as well as NYU's Occupational Therapy, USC, GW, School of Public Health, and we got a lot of different people involved to create this seminar where their students come online. And that's how I got involved with interprofessional.global. And that's what we're looking at with regards to, not all of these programs actually needed or wanted to necessarily participate immediately, but they did, but their accreditation doesn't mandate them to actually do this. And so I think that's something that we're looking at interprofessional.global, is to see where in the world accreditation exists and what universities are mandating this. So we're taking a look at that on different policy levels. I also work for the federal government and I do disaster. And so that's one of my other interests in areas. And that's where my question is because I just came back from the Bahamas. I've been in Nepal after the earthquake, where I hiked to a village and we reported to the WHO there, but somebody else had already gone there. So we hiked 6 hours to a village and somebody was there and had already taken care of the people in the community. So one thing that I see in disaster care is that there's a lack of interprofessional education, sort of going on what the gentleman in the green had said earlier about systems and all these different areas. There's a lot of NGOs that participate in disaster and a lot of federal policy, and I don't see a lot of communication. I see everybody wants to get there, everybody wants to do something, everybody wants to help. So I guess my question is, how do we increase that in the disaster workplace and mitigation of disaster in order to be able to play in the sandbox well together?
So I'll take a tack. I actually started out working for the International Rescue Committee, 20-some years ago, and I think, and I keep in touch with some of the folks, and I see some things have changed, but some things have not. And this was the same discussion 20 years ago. And I think sometimes there's multiple factors. Part of it is just the way programs are structured, funding is structured. It actually and actually I think academic institutions often are. We're designed to compete rather than collaborate. We're not made ready to work together. So again, education isn't one, but I think, have to work to create an environment where this, when the outcome is clear and find a way to, on the ground, also, at that point, this 20 years ago in what was then Zaire, we came at it was the most wonderful interprofessional collaboration I've ever experienced. We came in at a time when they weren't letting NGOs in. There was a civil war raging. Folks it came in a very small group. We all sat down, who has a driver, who does health, who does water and sanitation, etc. And people came together and did amazing things. I came back 2 months later, and the funding streams had come. Everybody was competing for proposal, and that broke down. So not to say, I think it can be done, but I think there are larger structures that kind of pull us apart. So we have to figure out ways of creating these joint platforms and conversations and not give up on it, because when collaboration works, it really does amazing things.
Sure. I'll be quick. Yes. So we've been doing a lot of thinking around the concept of resilience in health systems, and and a lot of that comes from sort of disasters and observations that systems are not resilient in the time of disaster. But really, what we've come down to is there's expected and unexpected crises, and if we get better at dealing with the expected crises, the health worker strike, or just the health worker not there because they're busy picking up their paycheck, and how does the system respond to that? Can they redeploy resources? Can they work from a broader community on those sort of expected emergencies that happen on all the time? If we can get better at dealing with those, and hopefully we'll be better at dealing with the unexpected ones.
Okay, we have time, and I apologize just for one more question. Because we do have a summation, we have to leave the room. So please.
Okay, I'll be quick. Dan Peterson from the G4 Alliance, the Global Alliance for Surgery, Obstetrics, Trauma, and Anesthesia Care. And as we think about, we love the things we heard about making the preventable deaths no longer the normal. In many cases, surgery can help make preventable deaths prevented and transform lives. But we know that those are often the most difficult elements of the workforce to fill up, right? To recruit, to train, to develop the surgical related careers and professions in the LMICs. So what can we do as a policy, as funding, to attract, retain, develop, train the people we need in surgical related professions within low and middle income countries, so we truly can have true universal health care?
Jim is our default respondent. He's up to it.
I mean, I just like, thanks, Dan, and then G4 Alliance, great work that you're doing there, like many of the other professional groups that were in the room, the med students, the Wonka, the others that are here. The countries don't tend to plan based on occupation. And especially when we talk about socially accountable, it's based on population need. And clearly, if you break down population need, the essential surgical interventions are at the heart of a primary healthcare system, as well as the specialist referral. Road traffic accidents, pediatric injuries, and often it's the first point of connection with the healthcare service is through trauma, or the unexpected. So we need to ensure that it is absolutely built in. We're seeing, and then we've got to start to look at, okay, well, what is the volume of potential population requirement translated into a workforce in the future, and how close we are not to that. But we're seeing some really good examples of building the workforce. I mean, some of the work of COSEXA in partnership with other surgical schools and colleges around the world, building national capacity, retention, training, identifying from within, training for the population need, ensuring the employment opportunity is there so these people are not migrating elsewhere to actually come forward. But we need more investment. We need to come back to the biggest thing, the data use to create that thing and create the jobs. And if we can't create jobs in these economies, that's going to be the major challenge. And that's the same in high income, low income countries. So we've got to connect it to this. So it's all occupations, but I do recognize in particular that component of primary healthcare and trauma that we need to include in that.
I want to give thanks to each of the participants on both panels and our moderators for a really fascinating discussion. I think we really exceeded our expectations in terms of having a multidisciplinary conversation and touching many, many topics. Björg's going to summate in a minute, and I just want to remind you all there's the accreditation meeting in Istanbul. That's very important, and look for those reports that will be coming on workforce. And then just finally, I think we're at a rich time in terms of policy. And one of the biggest lessons I had from my experience during my policy studies was perverse incentives and unintended consequences. And Jim, you reflected very carefully and talked about some of the problems in terms of education becoming a for-profit area. And that is just one example, and we have many of the opportunities with universal health coverage. There will be a rise of private sector delivery. We want those to be accountable organizations. We want them to be quality organizations. In terms of the medical education piece, we are in this country facing a shortage of 55,000 primary care physicians by 2030. Last year, 600 residents did not match for their residency. So we have nurses who are coming out of not only high-income countries, but low-income countries that do not find employment because oftentimes governments and private sector will not pay what they need. So the priorities need to be, patients first, our health workers second. And if we keep those priorities straight, I think we can be accountable at the end of the day and not make it other priorities in terms of profit and et cetera. So thank you all. Please, Björg is going to summate. NYU has been an incredibly generous host, the Department of Population Health. We have the space for quite a while longer. There's no conference on the tail. So if you want to hang out and talk and ask your questions of each other and get to know each other better, please do stay. Björg.
So it's actually hard to summarize. There were so many good points and important points that came through. I think obviously Francis' comment about what's acceptable and what's not, and sort of get us off, accepting some things as just the way things are is not. And yesterday, a milestone was reached, a political declaration signed by countries that universal health coverage is where we're heading, was signed. It's a milestone and it's fantastic. But we also had the climate summit, and again, health is central to that as well. However, as Greta Thunberg said, global agreements are great, but action is what matters. And I think that's where we're at. And action is actually taking place. It is not just people are doing this, all around the world, and a lot of us don't know about it. So another point that I think we need to keep in mind is we're only as good as the team. And I think that is the interprofessional. I mean, I struggle with these terms, but the team part needs to be at the core, because no one profession, no one sector is going to address this. And it also has to go beyond universal health coverage. It has to focus on quality and their education, not just pre-service, like Marilyn was saying, but throughout. We need to create lifelong learners. We need to make sure that whether it's community health workers or others are integrated in the system, they get the education and support that they need. And I think another thing which is very clear is that we need to focus on gathering meaningful, actionable data, not collecting, using actionable data, but really I think this is something that we often have shied away from looking at what's hard to measure, because we do need to look at the difficult things. Issues like trust. If you take the Ebola crisis, trust was at the core of the response. So we need to change the way both that we educate our health professionals, but we also need to change the way we work with other stakeholders and all our partners. So I think one of the things that you know comes up is again the whole definition of social accountability and where that is, what that actually means. And THEnet has been focusing on, what we've tried to focus on is we've been working with people, practitioners in the field who weren't necessarily published. They weren't out there because they were so busy doing the work. And I feel actually quite embarrassed sitting here talking about them. And some of them are out on the webcast, but that's the folks who are really doing the work on the ground. And we have to get these stories up. And I think if that's one place where THEnet has been successful, is helping them tell their stories and maybe helping them with some research tools and partnerships to actually evaluate and measure and then go back, revise the curriculum, revise the strategies. And what we found with all of the schools, that partnership was at the core. I also think that what we do need to do is be better at mapping. The accountability part is important. It's not only the education sector. We need to make sure there's quality education, like I think what Jim mentioned, you know, in terms of this whole proliferation of private institutions. Doesn't necessarily have to be bad, but they have to be held accountable. Health workers have to be held accountable, but to whom and for what? And communities have to be central. Now, community is this broad, amorphous things, but we need to define them, because how do we know that we're serving those communities if we're not talking to them, if they're not part of the decision-making process? It's our patients, but it's their families and beyond. So I think, you know, what I'm away with is there's a lot of great things happening. We need to map and track, and we need to find ways of overcoming our fragmentation. I know there was, I think, seems like so long ago, but I think it was Saturday when the WHO had this very important event around investing in health workers. And the Minister of Health from Norway was talking about this 1-to-9 return on investment in the health workers. And again, that's why health workers have to be priority, but education is a really essential part of that. He called for starting this $1 billion fund in order to invest in health workers. Unfortunately, very often the funding is still happening in silos, but I think it's wonderful work that the USAID having an office on health system strengthening is really at the core. So at a recent conference in Australia, I'm trying to find the word because Akiko Maeda, who used to be both at OECD and the World Bank, had some wonderful terms that she used that I think are at the core of social accountability. I think it was Ikugai and Kizuna. And Ikugai was around purpose and meaning. And I think we all have to gather and come together around that purpose and that meaning. And then Kizuna, which is around connections, working together and partnering. So to me, perhaps that's the essence of social accountability and the essence of our charge going into the future. Thank you so much for attending.
The symposium, excellent, wonderful. In a few days off, Kelly, come and join us.
Kelly, please run it.
I think if they get the right visualization. Okay, I'll figure it out.
Yeah, nice to meet you.
I'm not able to have mine.